Cardiac amyloidosis. The clinical presentation of amyloid light chain type cardiac amyloidosis. The heart is affected more than 75% of the time, the kidney more than 60% of the time, and hepatomegaly is seen in more than 50% cases. Cardiac symptoms are mainly due to congestive cardiac failure, heart rhythm abnormalities, and valvular heart disease. There can be nephrotic syndrome also. Other manifestations include autonomic neuropathy, macroglossia, periorbital purpura, and peripheral neuropathy. The most important extracardiac signs of ATTR amyloidosis is bilateral carpal tunnel syndrome, ruptured biceps tendon tear, lumbar canal stenosis. The red flag signs are low or normal blood pressure in a patient with previous history of hypertension, intolerance to beta blockers or ACE inhibitors, history of bilateral carpal tunnel syndrome or atraumatic biceps tendon rupture, orthostatic hypotension, macroglossia and or periorbital purpura, a new diagnosis of HCM in an elderly patient, new diagnosis of low flow, low gradient AS in an elderly patient, and heart failure with preserved ejection fraction with nephrotic syndrome or peripheral neuropathy. The diagnosis. Different scientific societies have incorporated the following diagnostic modalities in combination: red flag signs, tests for monoclonal protein identification, that's a serum free light chain, serum immunofixation, urine immunofixation, electrophoresis, ECG, echocardiogram, CMR, bone scintigraphy, tissue biopsy, and genetic testing. The tissue biopsy provides the histological diagnosis. It should also be done where bone scintigraphy is borderline positive in association with absent monoclonal protein. The gold standard is an endomyocardial biopsy. Sampling from more than 4 sites provides 100% sensitivity and specificity to diagnose cardiac amyloidosis. It is confirmed when the EMB sample shows Congo red positivity. Staining to confirm the presence of amyloid subtyping determined via immunohistochemistry or mass spectrometry is more accurate. The limitations are the echo and the MRI are not sensitive or specific for early disease. The endomyocardial biopsy is invasive, but it's very sensitive. The management. The treatment is aimed at eliminating the plasma cell clone producing the amyloidogenic light chain. Drugs are the reduction of light chain production by bortezomib, carfilzomib, ixazomib, lenalidomide, and venetoclax. Amyloid fibril formation inhibitor, doxycycline. Removal of amyloid deposit or the antifibril treatment, CAEL-101, and birtamimab. Anti-CD38 therapy, daratumumab. Orthotopic heart transplant. While there is no cure, we can delay the progression of it. Treatment modalities include chemotherapy, immunotherapy, and organ transplant. The management of heart failure, sodium restriction, loop diuretics, and aldosterone antagonists are effective. Torsemide is preferred over furosemide. Beta blockers and ACE inhibitors are neither effective nor well tolerated, but in AF you can give beta blockers, but amiodarone is the first choice in an AF. Non-DHP calcium channel blockers bind to the amyloid fibrils, so are contraindicated due to the risk of profound hypotension and syncope, and digoxin is also avoided. Anticoagulation is needed in AF patients, pacemakers are indicated in heart block patients, and the role of ICD is controversial. Genetic testing is very crucial in ATTR type when the identification of the gene is of utmost importance. The summary of treatment: ATTR-WT with cardiomyopathy, give tafamidis. ATTR-V with cardiomyopathy only, tafamidis. ATTR-V with cardiomyopathy and polyneuropathy, tafamidis in polyneuropathy stage 1, patisiran in polyneuropathy stage 1 and 2. ATTR-V with polyneuropathy only, tafamidis in polyneuropathy stage 1, patisiran and inotersen in polyneuropathy stage 1 and 2.